Hello, everyone. My name is Gavin McDonough, and I'm the Educational Action Supporting Officer at ERN-EuroBloodNet, and I'm happy to welcome you to the fourth session of GenoMed4All and ERN-EuroBloodNet's educational program on artificial intelligence and hematology for an expert audience. This collaboration with GenoMed4All is the result of many years working together since 2021, and this year's program aims to increase awareness of the cutting-edge advances of artificial intelligence and its implications in the field of hematology. And on that note, I'm happy to introduce our speakers for this fourth session. The speakers are Elizabeth Sota and Severio D'Amico. So today's topic is the use case MDS overview of results, both from a technical and clinical perspective, plus specific onboarding requirements. So Elizabeth Sota is a bioinformatics scientist at Humanitas AI Center with over 10 years of experience in translational cancer research. Her work focuses on developing integrative models to analyze clinical and omics data through statistical and AI-based techniques for aiding clinical decision-making for personalized medicine. And Severio is an AI team leader at the AI Center of the Humanitas Research Hospital Institute in Milan. At Humanitas, he deals with generative AI with synthetic data generation, is mainly active on the European projects GenoMed4All, of course, and Sistema, whose objective is the use of advanced and innovative technologies for personalized medicine with particular attention to explainable AI processes. Since 2023, has been the CEO and CTO of Train, a spin-out of Humanitas specialized in the development of generative AI technologies in the healthcare sector, such as synthetic data and digital twin. So with that, I hand the floor to Elisabetta. Thank you very much, both of you, and thank you all for joining.
Thank you very much, Gavin, for this nice introduction, and good morning, everyone. I'm Elisabetta Sauta, and I work in the team of Professor Matteo Della Porta in Humanitas. And actually, I will present you our key result within the GenoMed4All project and within the myelodysplastic syndrome use case. Let me briefly present you the clinical context in which we develop all of AI solution that now we will present you. The myelodysplastic syndrome is a group of disorder that are involving the bone marrow microenvironment and lead to an ineffective hematopoiesis. Myelodysplastic syndrome are a rare hematological disease, and patients rapidly evolve into a worse disease, that is the acute myeloid leukemia. Patients are characterized by high heterogeneity in their clinical courses, and more than 80% of these patients are hit by somatic mutation on key relevant genes for this disease. These patients are not only characterized by high clinical heterogeneity, but also in their genomic background, because patient has in median 4 or 5 mutation on relevant genes, but the pattern of these mutations are quite different among patients. So as you can imagine, this is a multifactorial disease, and other elements concur to the disease onset and evolution, like factor linked to the immunological part of the bone marrow microenvironment, and also on in the inflammatory part of this bone marrow microenvironment. Actually, the classification of these patients for their risk stratification relies on morphological and genetic abnormality defined by the revised international scoring system that is actually used in clinical practice. This, of course, determined some disease management issues because this current prognostic classification failed to capture the individual patient heterogeneity. And the majority of these patients failed first-line therapies, in particular for the hypomethylating agent therapy. The only potential curative treatment for this patient is the hematopoietic stem cell transplantation, but not all patients are eligible for this therapy. And since the myelodysplastic syndrome is a disease that hits elderly people, the only time window for this patient is around 70-75 years of age. And even if the patient underwent 2 transplantation, there are mortality and morbidity events that are linked to the procedure used for the transplantation. For all of these reasons, a personalized risk stratification strategy is mandatory. And this is the goal of our mission in GenoMed for this use case. The major aim is the development of AI solution to improve the clinical management of this patient, and in particular using a personalized medicine approach given the complex disease scenario that we are accounting for. In particular, in this mission of this project, we have 3 main aims. The first one is linked to the MDS prevention based on the genomic screening, given the genomic heterogeneity for this patient. The second one that is linked to the first one is trying to define AI solution, AI algorithm that can help the classification and the prognosis of MDS patient using different data modalities, not only the clinical and the genomic, but coming from other omics data layer. And the final goal that is defined by the omics-based clinical decision-making in myelodysplastic syndrome is the final goal that having a clinical decision support system that can help clinicians in selecting the best treatment option for this patient and improve the diagnosis and the prognosis of this patient, especially for the transplantation policy for this patient. Regarding the first aim, I will not go more in depth because this part will be presented by Saverio, but in this year we developed and successfully published and implementing in other works a special framework for the multimodal analysis, and that is based on artificial intelligence, of course, methods, both supervised and unsupervised, trying to better improve the risk stratification of this patient, but also helping clinicians in interpret the result of this framework. Taking as input clinical and genomic features, this framework use unsupervised and supervised methods, and then as an explainability implementation to help clinician in understand the result of this framework. We use this mosaic framework, for example, in an important clinical work. A big effort of the International Consortium for Myelodysplastic Syndromes, in which they are trying to define a consensus classification, data-driven, so is driven by clinical and genomic feature of this patient, trying to harmonize the actual classification that are present for this patient. And then we also apply this mosaic framework in a big study that is called the TITA study, that collect all data from all myeloid neoplasm, and also we have a specific focus for the chronic myelomonocytic leukemia. And actually, the result of these 2 works will be presented as our presentation at the American Society of Hematology conference that will be held in San Diego in the next December. But Saverio will go more in depth regarding this first aim. Just switching to the second the aim of our mission, let me say some word about a new score that was introduced the last 2 years by the International Working Group for Prognosis in MDS. Given the heterogeneity of this patient, in particular for their genomic background, this group proposed a new molecular score that expand the previous scoring system that is called the revised scoring system that exploits demographic and blood parameters and also cytogenetic alteration information of this patient. This group proposed to introduce also the somatic mutation on 31 MDS-related genes, trying to better stratify the risk linked to this patient. Effectively, they demonstrated that this new score can better predict the probability of survival and leukemic-free survival for this patient. And what we have done on behalf of the GenoMed4All consortium was to provide the first extensive validation of this score in a real-world myelodysplastic syndrome cohort of more than 2,000 patients. What we want to demonstrate with this work was the effective clinical implementability of this score, since that is new. And in particular, we wanted to address three main points, trying to validate the prognostic value of this score in terms of predicting the probability of survival of this patient. But in particular, we wanted to answer how is impactful this score in terms of predicting the survival after transplant and after disease-modifying therapy like hypomethylating agents, because this point was not addressed by the authors of the IPSSM. And then, given the fact that not all hospitals can affront the problem of next-generation sequencing, that is an expense, trying to sequence for having the somatic mutation information for all the patients, we wanted to evaluate the prediction accuracy of the new score when the genomic information is missed, for example, for some of the 31 genes. So what we have done, and we are, of course, we answer to all of the, we address all of these 3 points. We effectively evaluated the prognostic power and the prognostic accuracy of the IPSSM compared to the old score across all clinical endpoints, of course, the overall survival and leukemia-free survival. The IPSSM effectively improved the prediction of relapse after a transplant and the probability of survival of patients that have undergone to transplantation, but this score failed to stratify the risk of patients that receive hypomethylating agents as a first-line therapy. Then we are able to define, trying to simple simulation, removing one gene at a time or more than one gene. We are able to define a minimum set of 15 relevant genes that guarantee an accuracy of the score in risk prediction of more than 70%. So in this work, a clinician can be informed that if he does not have the information for all the 31 genes, looking at this study, you are able to know which is the accuracy linked to specific gene that is missed in your polyp. And starting from the conclusion of this score that the score is not able to stratify patient for the probability of response in hypomethylating-treated patient, we switch to another idea that we called the multi-omics project. That is a very big project, because if the clinical and the genomic information is not enough to stratify patients in terms of disease-modified therapy, we want to collect other data modalities for these patients. So with a big effort on more than 400 patients, We collected not only clinical and genomic information, but also transcriptomic information. What is a transcriptomic information? Is the information that comes from the gene expression of particular cells in the bone marrow. These cells are the tumor cells that characterize myelodysplastic syndrome. So what we want to know if these cells are associated to altered biological pathway using the transcriptomic information, which are the biological activities that are altered due to the disease. Then we also collected the immunomic information using flow cytometry experiments because we wanted to investigate the immunological part of the disease that is characterizing the bone marrow microenvironment. And then also we collected for all of these patients the digitalized histopathological images at different stainings that are used in the clinical practice to understand the morphological texture of the bone marrow of this patient, to define the diagnosis of this patient. So the big aim is to develop multimodal integrative models able to improve the clinical decision process of this patient to have a personalized diagnosis, prognosis, and also treatment option. In particular, we started from what has been done actually in the literature with a simple statistical model. Why we choose this option? Because we wanted to have a simple model trying to understand which is the contribution of different data layers. And actually in the literature, the only work that has been published is the work of Gerstrung. That is the only actual study that evaluated the transcriptomic contribution for myelodysplastic syndrome patient with a simple statistical model, for example, the penalized Cox model, and that is more understandable for clinicians. We added the added value of this work that we have done is not only to evaluate the transcriptomic contribution on with a simple statistical model, but also to compare the performance of the model in terms of concordance. So we wanted to know the ability of the model to better stratify patient, to better predict the survival probability of this patient. We wanted to compare this more integrative survival model with the model that use IPSS-R and IPSS-M related features. And this was missed, of course, in the work that was published more than 10 years ago. And then also we evaluate in terms of explained variance, which is the impact, which is the contribution of each data layer that we use in this model. What are the advantages of this study? Of course, this interpretation of the results, but more are the disadvantages of this model because, as you maybe know, a statistical model has a limited number of input features. And these limit also the possibility to integrate a huge number of features that coming from transcriptomic. For this reason, we perform a sort of manual feature extraction and feature reduction using, as the author of the published work uses the principal component analysis. And we exploit the first 20 principal component that explain the 42% of variance of the transcriptomic information. But this is not, in our opinion, the correct way to process this data, because we have a huge number of features that can depict the gene expression profile of this patient, and now we are reducing with this combination of variables their power. So starting this pioneer work in which we define the contribution of the transcriptomic information, we switch to more complex models based on deep learning models. And actually for this big project, we have several collaboration to trying to define diverse model that can, as a unique aim to improve the personalized medicine of this patient. So thank to the University of Bologna, the University of Torino, SISSA Institute in Trieste, and other institute in Milan, we are trying to define a different model that can compose a multimodal driven platform to improve the risk prediction of this patient. And in particular, as Humanitas part, in collaboration with the University of Torino, we are trying to define a multimodal model that has two main components. One that is based on a foundation model we are trying to that is fine-tuned for the hematological domain, of course. And we are trying to segment and extract features from digital pathology images, and another layer in which with other deep neural networks, we are trying to extract information from all the other data modalities. Then we want to combine the extracted features and have a personalized risk prediction for each patient based on the patient profile. This workflow has, of course, an explainable part in which we want to, that is based on Shapley value, in which we want to explore the impact of all the variables used in input and which is the most impactful variables in terms of risk prediction. And this will allow, of course, a clinician to understand the result of this complex framework. And we applied this framework on a cohort of more than 400 patients, and these are the preliminary results of our framework that will be presented at the American Society of Hematology in December in San Diego. And we evaluate the impact of each data layer in terms of concordance, and also which is the impact of adding each single layer towards the multimodal integration. And we reached a good concordance of 85%, and also we compared this concordance with the IPSS-R and IPSS-M scoring system. The last part, but not least for importance, is linked to the third aim of our mission. And we, with the collaboration of Polytechnic of Milano, we are able to develop a decision support system to suggest which is the optimal timing for transplantation using the specific profile of the patient. In particular, we trying to model the natural disease history, the natural step of this disease that for a patient that is has not a transplantation policy, this patient could evolve in AML or experience the death. For a patient that has the transplantation, we wanted to estimate which is the probability of relapse or and death, or only the probability of death after transplant. We use a semi-Markov multi-state model with microsimulation using as input agent sex as a covariate, and IPSS-M and IPSS-R as a sort of surrogate variable that resume the information coming from clinical cytogenetic and genomic information. Using this simulation, we have different patient trajectory in which we are want to estimate the risk of pass from one state to another state. And what we finally reach is to have a sort of graph in which we are able to evaluate which is the optimal timing for transplantation using an average survival time in a time horizon of 8 years. And what we end up is that for a patient that is in a low and moderate low risk category defined by the IPSSM score, for this patient, a delayed transplantation policy is recommended. For a patient that has a high and very high risk category defined by the IPSSM scoring system, of course, an immediate transplantation is mandatory. And after we define all of this framework, we implemented the framework in a web tool that can be used for research. That actually was developed for research purpose only, but is the final goal in which the decision support system that we implemented can be translated into a data portal in which a clinician can enter the patient information and as output a graph, a plot in which the optimal timing of transplantation is recommended for this patient using his individual characteristic. And for this part, for me is all. I want to acknowledge the European Reference Network and the GenoMed4All project for this opportunity, and of course, all of our collaborators of different institutions, my colleagues, both from the clinical and technical part in Humanitas, and of course, you for the attention.
Great, thank you so much. Wonderful presentation. So now we can pass the floor to our fellow guest speaker, Severio. The floor is all yours.
Yeah.
Thank you.
Absolutely. Thank you so much. Thank you so much, Gary. Thank you so much, Elisabetta, for your presentation. And good morning, everyone. So once again, I'm the AI tech lead of the AI Center of Humanitas Research Hospital, and my focus on work is to develop AI solution based on generative artificial intelligence. In these years of our research, we focus our main research in the synthetic data and digital twin technologies. And today I want to present you some of our application and overview of solution and results that we reach in these 3 years of working in particular in the MDS use case. First of all, when we talk about artificial intelligence and the other kind of application, the most important part is that we need data, and in particular in medical data and real-world evidence from medical data. But the major issue about clinical data is that right now the 97% of the data, of healthcare data in particular, remain unused inside the hospital. The main reasons is for example, privacy limitation regarding GDPR compliance and the lack of data harmonization from different sources, in particular in a hospital center. Every one of us knows better than me, maybe, but in a hospital is very complex to find a complete harmonized platform of data. And last but not least, data are not structured, and they are dispersed, in particularly for different kind of data. For example, in rare disease, when multimodal data are typically used for classify better the disease. So considering this major issue in the healthcare data, one of the major technology that can help in this part in solving this issue is the synthetic data. Synthetic data are basically artificial data created by an algorithm, created by artificial intelligence, and this kind of data are neither a representation or a copy of the real data, but is a brand new data based on the statistical characteristics of the real data. Of course, the advance in the use of synthetic data is that beside the part that synthetic data are totally anonymized data set, but plus with respect to the real anonymized data set is that the synthetic data are smart data. So I can create a synthetic data without any missing data, without any missing information. So this is the main characteristic and the main advance in the using synthetic data instead of anonymized real-world data. The main, as I said you before, synthetic data are artificial data created by an artificial intelligence model, and in particular one of this kind of model that we used for the MDS use case is the GAN, that is the Generative Adversarial Network. It is in particular an artificial intelligence architecture based on two different models. The one model is a generative one, and the other is a discriminative one. So the main goal of this architecture is to create a competition between the generative model and the discriminative model, because the aim of the generative model is to create brand new data, brand new artificial data, very similar to the real one. And the aim of the discriminatory model is to discriminate which is real and which is artificial. So basically, after the training process, after the competition between these two sides, at least we reach an equilibrium. We reach a consensus part and then we have a generator model which is capable to generate artificial data very similar to the real one. So as I said, the main properties of and the possible application of the synthetic data, beside that data sharing, avoiding privacy and GDPR issues, are of course the class balance and the resolution of missing information. So we reach data harmonization with this part, and of course data augmentation, because with synthetic data we can decide the amount of data to create and the characteristics of the kind of data we want to create. For example, we can choose the number of patients and the specific characteristic of patients we want to generate. Then the generation of new evidence, because we can use synthetic data for a couple of clinical application and clinical research with this data, in particular for rare disease part. And now I will show you some of these applications. First of all, I want to give you an overview of the practical application of synthetic data in the myelodysplastic syndrome use case. You know, Elisabetta told us a very complete overview about these diseases, and in particular, the main reason is that this kind of disease is very complex. Beside the part that these are rare diseases, so we have very few data with a high heterogeneity, but this disease is characterized by multimodal information. So we have the clinical information, the genomic information, the imaging information, the morphological information from the images. So a lot of data with different type. So we have to, in some way, to dealing with this multimodal information. In synthetic data, this is a complex issue because we have different kind of information to synthesize, but that's why we need a very complete and powerful model, completely training on real-world information. In this example, I can show you how synthetic data in myelodysplastic syndrome help us to create a new cohort of patients with a very strong validation, considering the WHO subtype and considering the frequencies of the gene mutation in the cohort of patients. As you can see, synthetic data training on real-world evidence and specifically to MDS disease can help us in generate brand new patients with similar distribution of frequencies and subtype of MDS patients. Looking at genomic information, we see that both real and synthetic data. So we see that synthetic data in some way results in a very strong how can I say, in a very strong information between the genomic abnormalities and the genomic co-occurrence of patients in real and synthetic one. So this is basically a correlation matrix between the interaction of the co-occurrence mutation in both of data set and the interaction between the co-occurrence of each genes for all of the cohort of patients. As you can see, the design of these graphics are both similar in real and synthetic data, which means that in the synthetic cohort, we have the same relationship between genomic alteration in each patient. And another important part is that the synthetic cohort of patients in this case is an augmented data. So based on the training cohort of real patient, that is about 2,000 of patients, we created three times cohort. So basically 6,000 of patients, and also in this augmented data set, we reach the same characteristics based on genomics informations. Another important part is looking for the survival application, the overall survival in both real and synthetic data. As you can see in this graph on the left, we have the same behavior of the survival curves in different class of risks between real patients and the synthetic patients. The really important part is that the curves, the Kaplan-Meier curves, are not the same, because as you can see, are totally different curves, but with the same behavior and the same behavior in times. So that means that the both of data set, real and synthetic one, are totally different data set, but the cohort of patients have the same characteristics. So we can use these brand new synthetic data for survival and clinical analysis. For help clinicians and researchers in using these advanced technology for the generation of synthetic data, we created a web platform, a web application in which, as you can see in the image on the right, in which you can set up, you can write the number of patients to generate, and you can also validate with this clinical analysis the synthetic patient generated. Of course, when we talk about artificial intelligence in healthcare, is a very critical situation, and particularly because we are talking about patients' data and patient information. The WHO in 2021 gave us three main guidelines in developing AI models in healthcare application, and these guidelines are the transparency of the model, of course, both within interpretability and explainability, the reliability of the models, in particular using generative artificial intelligence technology, and last but not least, the protection of data and data sharing, because all of that model have to follow the compliance with GDPR European guidelines. And considering that, we developed a synthetic validation framework that following all of these three guidelines from WHO, and that basically told us if the synthetic data generated are good enough to be used in a clinical application. We create this validation framework to inform us about three kind of metrics, in particular in the MDS context. The first one is the synthetic clinical fitness, that basically explain us how good is the synthetic data in terms of clinical characteristics and relationships between real and synthetic data. And this is an average score. This is a percentage, so basically from 0 to 100. And as you can see, in all of our experiments in the MDS use case, we reach more than 90% of clinical fitness, clinical fidelity in the synthetic data. Second metrics is the same fitness fidelity metrics for the clinical data, but this time for the genomic relationship, the genomic alteration, the karyotype abnormalities. Also in this part, in all of our experiments, we reach more than 90% of fidelity also in the genomic part. Last, we have the privacy preferability metrics, because of course the major issue in synthetic data is to be sure that in the brand new synthetic data set generated, there are not any real patients from the training cohort. correct. So that's why we developing this privacy metric based on distance metrics between real and synthetic data. And this time the best range about these privacy metrics is not 100%, but it's something between 60 and 80%, because of course if we have 100 of privacy metrics, we have totally completely different data set without any strong relations with the real one. And other side, if we add 0% of privacy, we have completely the same copy of the real data. So the privacy metrics is sort of we need to reach a trade-off between utility and privacy. Now talking about the application of the synthetic data in the MDS use case, the most advanced and important application of this data, of course, is in the clinical trial, because with synthetic data we can generate a synthetic cohort of patients to be used in clinical trial, in randomized clinical trial, maybe to completely substitute the real control one with a fully synthetic control group. We set up an experiment in the clinical trial, in particular in this clinical trial for the MDS use case, in using the luspatercept treatment for MDS patients. In this experiment, we basically recreate the clinical trial, but using a synthetic cohort instead of the real control arm. And as you can see, comparing all of the endpoints of the clinical trial using both real and synthetic arm, we reached the completely same results in both the experiments. So that means that considering the clinical endpoint, we basically would have the same results in using real and synthetic data. As you can see also in the survival curves, in the Kaplan-Meier curves on the right, once again, the Kaplan-Meier curves are not the same, but the behavior still remains the same. Because once again, the control group are not the same, are not a copy, neither a representation of the real one, but it's totally a brand new data with brand new patients, artificially, but brand new. Of course, that's in clinical trial helps a lot, potentially helps a lot in go ahead the limitation and the potential pitfalls of the randomized control trial, the RCTs. Of course, everybody knows about the limitation of RCT. Right now, RCT, of course, are the major tools that we have in drug development and clinical trial, but of course, they have some mitigation and some limitation. And in particular with patients with the major unmet clinical need and critical situation, think about the most critical oncology situation in which, for example, the use of placebo arm or the use of a control arm maybe is not ethical at all with respect to the patient. And that's all in the most critical part, most critical part. Right now, we have some examples of the using of synthetic data in clinical trial, reaching the approval of the, for example, in this case, FDA. This is a couple of examples in clinical trial that use the synthetic data as a control arm and obtain the approval from the FDA. We have example from different pharmaceutical company, for example, Pfizer, for example, Merck, and so on. And last but not least, in 2022, the FDA created an alliance with the scientific community in START, a new research program in using synthetic data in clinical trial for synthesize the control arm for the colorectal cancer, cancer, to avoid the placebo, in the clinical trial to the control arm. This is called the No Placebo Initiative, and is a very great opportunity, because beside the part of using innovative technology, we can really help the patients avoiding the use of placebo in this critical situation. Synthetic data are, of course, more than tabular information. for example, clinical or genomic part, of course, we can generate a sort of multimodal information. Elisabetta, in the previous talk, informed us about the importance of the multimodal information to enhance the quality of the model, enhance the power of the prediction, and enhance the at least the introduction of personalized medicine. So of course, with synthetic data, we can create not only tabular information, but also multimodal information to enhance the power of this predictive model. And in particular, at the pillar of this part is to create a very strong model with a very strong training based on real world data. In these times, you know better than me, we have a lot of generative models, ChatGPT, Google, a lot of one with very capable of information. For example, ChatGPT right now can generate text data and also images. But how about medical information? How about medical data? In this slide, I provide you an example in using a very powerful generative model between a generative model versus a domain-trained generative model trained only on real-world healthcare data. Using a generalistic model like Stability Eye, the base of ChatGPT, for example, we cannot create, for example, histopathological images because the model do not have a strong training on healthcare data. So on the other hand, using a domain-trained model can help us in understand better to how to create data, how to create data useful for the predictive model. And of course, we also created a generative model that can help us in creating synthetic images starting from the medical text report. So we can create basically a lot of histopathological images starting from medical text reports, starting from the diagnosis of the patients, of treatment information. So every kind of information that we can find in the medical text report. Of course, one of the most important part is the validation, once again, of these synthetic images. Our validation framework for the synthetic images is based on looking inside the images and extracting features, for example, morphological features like the number of nucleus or the size of the nucleus, or information about how many fibrotic area of fibrosis in real synthetic images, and so on. This is in particular an example of how using synthetic images to enhance the number, to augment the number of real data can help us in reaching in enhanced predictive model, reaching the most accuracy in predicting the survival. In particular, as you can see in this experiment between the model 1 part and the model 3, and the model 3. Using more data, of course, enhance the performance, as you can see from model 1 to 2, because in model 1, we are using only less than 200 patients, and in model 2, less than 300 patients. And of course, these obviously, when we increase the number of patients, we increase also the performance of the model, but this is with real data. And in model 3, we can see that also using synthetic data to augment our cohort of patients, we can reach the same performance that using only real data. So once again, synthetic multimodal data can help us enhance the performance of a predictive model like this one for the survival part. Now talking about this AI-based framework, which is called Mosaic. Elisabetta told us, give us a preview of this framework to collect all of multimodal information, in this case, in particular for genomic and clinical feature, to to after classify the patients according to the classification of disease and predicting the survival, so making basically a prognostic assessment for individual patients. We created this framework to be used in different settings, in different use cases, also integrated with the federating learning platform developing in the GenoMed4All program. An example of application of this framework is in our very last research about about a comprehensive classification of the amyloid in neoplasm, based of course on multimodal information such as the genomic, morphological, and histopathological features. This is called a Titan study because a very huge study. We collected more than 20,000 of patients with different myeloid neoplasm between AML, MDS, and so on. And we use Mosaic framework to create a comprehensive classification based on genomic characteristics. We also, this is, for example, in the slide, you can see an example of the characteristics of the cluster 1 in this case, and how these characteristics are divided across the different disease classification and how the behavior of the overall survival, the leukemia-free survival in this example. To help, once again, the clinician in using this framework in this setting, we create an application, we create a web platform just to help in using the Mosaic framework in different data sets, in different diseases. Another example of the using of the Mosaic framework is in this very, very, very last research, because today, this morning, Lancet published this article. So I provide you the screen of the title for the International Consortium of Myelodysplastic Syndrome. We use Mosaic framework to harmonize the classification based on genomic feature this time. And once again, this was done using Mosaic framework as a tool for clinicians to help in collecting and analyze the whole of the multimodal information. Last but not least, I want to talk about the digital twin. That is basically one of the applications and the integration of this model for diagnosis, prognosis, and treatment strategy. And of course, creating a digital twin is a very complex part, because we have to develop different models for different clinical questions. As I said, clinic, diagnosis, prognosis, and treatment strategy. But of course, one of the major issues is the limitation, the lack of data, and the limitation of information. That's why synthetic data are completely linked to digital twin in providing data and providing synthetic data to directly fuel the digital twin model and help in validate this kind of model and provide information for the patient. Recently, we submitted also this work in the next American Society of Hematology meeting, and this is our results, building a comprehensive platform based on digital twin model, as I said, to answer 3 main clinical questions, which is the diagnosis, prognosis, and treatment strategy. And of course, we integrated also the Mosaic framework in this platform, and we use the synthetic data to fuel this platform, to validate this platform. Right now, we can put inside the platform the information, the multimodal information for a single patient, from demographic data, from age, sex, and so on, to clinical one, to morphological information, to clinical genomic information. And this platform can help us in bring a lot of data across all of the 3 main clinical questions. And with this, I'm done with the presentation. So I'm more than happy to help to answer some of your questions and so on. And thank you so much once again to EuroBloodNet GenoMed4All for inviting me in this webinar and for all of the initiative.
Great. Thank you very much for your presentation. Thank you both. As mentioned by my colleague Diana, now is a great chance to add any questions into the Slido.
Hopefully you can see them now. We have 2. The first one is basically to ask you guys if there is a plan already to release these tools across other European hospitals or clinics eventually.
We are actually develop our method in a federated framework to because we want to use these tools in a federated manner avoiding data sharing across hospital clinics and research institute, but we want that our developed tools can be used in clinical practice to help and implement the personalized medicine for these rare hematological diseases.
Yes, and regarding the second question, of course, it is a very important question because, in particular in rare disease, we have a high risk of re-identification of patients in the synthetic cohort. That's why we basically created this synthetic validation framework, because once we create the synthetic data, our framework informs us according to the 3 metrics that I show you, if we are totally confident that with the privacy metrics that it's impossible to identify a single patient. As I said, this is a trade-off, and the privacy metrics is basically metric based on distance metrics between the real data, a real single patient, and real synthetic patients. So that basically means that from a mathematical and statistical point of view, using all of the data, for example, the number of hemoglobin, platelets, and so on, of a synthetic patients, we cannot reconduct these for the real patients. Talking about model, using this kind of architecture, artificial intelligence model, the GAN, the generative adversarial network, from a theoretical point of view, it's impossible to recreate completely the real data, and that's because, as I said, using two kind of model in the training process, the generator and the discriminator. The generator model, the ones that create a new data, basically never seen the real data. So there is no information regarding the real data that come inside the generative model in this time. So that's why we handle the risk of re-identification of the real patient.
Great, and we also have a question from Sophie in the audience, and I can read that out loud. Could you replicate your work for the Repair MDS trial running in the UK, similarly to what you did for the, might need help reading this, Booster trial? Thank you very much.
Yeah. Of course, yet, as Elisabetta said, the major aim is not to develop model, closed model that can use also in a single application. So we basically develop our model beside the federating infrastructure, but also in a generalistic way. So, of course, our generative model can be retrained and fine-tuned on different disease, different application, and we can replicate every clinical trial, or we hope to use synthetic controller in actually also prospective trial. So basically, in a few words, the answer is yes.
Great, thank you very much for the question, and thank you both for the answers. And with that, if there's no additional questions, I just want to say a special thank you to both of our speakers today. So thank you all for your time.
Have a nice
and
day.
have a wonderful afternoon. Thank you very much.
Bye.
Bye-bye.
Bye-bye.